Good morning, everyone, and welcome to Thyroid International Recommendations Online. I hope everybody is doing well this morning, and I hope everyone here, at least here in the U.S., had a wonderful Memorial Day weekend. We are joined this morning by a truly international panel, which is very much in keeping with the goal of Thyro, which, as its name would imply, that we are, our goal is to be an international platform, and this morning could not be any more demonstrative of that. One of the drawbacks of being international is my challenge of introducing our speakers this morning without too much bungling of pronunciation. So bear with me as I go ahead here. This morning's topic is really a wonderful discussion about this relationship between thyroiditis and thyroid cancer. And this morning we are presenting a publication where the lead author, Dr. Simone De Leo, is an endocrinologist at Institute Oncologico Italiano at Milan, where he performs thyroid cancer research. He is the chair of the website and social media board of the European Thyroid Association and the editor-in-chief of Thyroid Research Journal. Following completion of his fellowship in endocrinology at the University of Milan, he was a research fellow at Boston University under Dr. Louis Braverman and Dr. Elizabeth Pierce. This morning's discussant is Dr. Haixia Guan, who is a professor and the deputy director at the Department of Endocrinology at Guangdong Provincial People's Hospital in Guangzhou, China. She completed her medical degree at China Medical University, where she was also she completed her medical residency and fellowship in endocrinology. In addition to publishing over 100 peer-reviewed papers, she has also participated in the development of Chinese guidelines for thyroid disease. Following her formal training in China, Dr. Guan received additional research training in the United States at Johns Hopkins, at Boston Medical Center, as well as at Brigham and Women's Hospital. She is the recipient of the Excellent Young Investigator Award from Fak Ying Dong Education Foundation and Ministry of Education. And so this is truly an educational panel this morning. And as always, we encourage all of our listeners to send in their questions regarding this very interesting topic. And I will do my best to get to those questions before the end of the hour. And so with no further ado, I'm going to ask Dr. De Leo to go ahead and begin his presentation.
Good morning, everyone. It's a really honor for me today to be here and have the opportunity to present the results of my study that has been recently published in the Thyroid Journal. The title of the study is a prospective multicenter study examining the relationship between thyroid cancer treatment outcomes and the presence of autoimmune thyroiditis. I have no conflict of interest to disclose, and this is the outline of the presentation of today. So we can start immediately with the introduction. First of all, I want to define what we need, I would like to define the associated thyroiditis, what it means. Thyroid cancer associated to thyroiditis refers to the presence of the thyroiditis in the normal thyroid gland. So this is completely different from the peritumoral inflammation, which instead refers to the presence of the inflammatory infiltrates around tumor cells. That means that the remaining thyroid parenchyma, in this case, is without signs of thyroiditis. Thyroiditis is presented as a lymphocytic infiltration that often meets the pathological and clinical criteria of Hashimoto thyroiditis, and for this reason, in several studies, is defined as Hashimoto thyroiditis. Thyroiditis may be defined either histologically as the presence of diffuse lymphocytic and plasma cell infiltrate with oxyphilic cells, the formation of lymphoid follicles, reactive germinal centers in normal region of the thyroid gland, or biochemically by the presence of thyroid autoantibodies. And if we look at the previous studies, we can see that autoimmune thyroiditis coexist with thyroid cancer and is reported this coexistence in around 10–60% among the several studies. In particular, Hashimoto thyroiditis coexists more frequently with papillary thyroid carcinoma compared to the other thyroid cancer histotypes, such as the follicular thyroid cancer or the medullary thyroid cancer. And the occurrence rate of Hashimoto thyroiditis in papillary thyroid carcinoma is 3 times more frequent than to benign thyroid diseases. A recent meta-analysis, a very large study, including 65 studies with more than 47,000 patients, tried to understand if there was, which were the characteristics of the patients with associated thyroiditis. In particular, in this study, only patients with papillary carcinoma were included in this meta-analysis associated to Hashimoto thyroiditis. And in this meta-analysis, the authors found out with all these studies and this very large cohort that patients with associated Hashimoto thyroiditis had a significantly lower rate of having central and lateral lymph node metastasis, a lower rate of distant metastasis and extrathyroidal extension, a lower rate of vascular invasion, and also lower stage and MESI score overall points. So the authors concluded at the end of this meta-analysis that the papillary thyroid tumors with associated thyroiditis have a less aggressive presentation at diagnosis. I want to underline here that in these tumors with associated thyroiditis, multifocality and bilaterality were more frequent when tumors was associated with Hashimoto thyroiditis. And also there was an association with the perineal infiltration. But I want to underline here that this data was obtained only from 2 studies with 130 patients. And if we look at the risk stratification system proposed by the American Thyroid Association guidelines, we can see that thyroid autoimmunity or chronic lymphocytic thyroiditis is not mentioned at all in this evaluation. And in the data set for reporting carcinoma of the thyroid proposed by the pathologist, these are the recommendations from the International Collaboration on Cancer Reporting. In this list of information that should be reported, thyroiditis is not reported, and they only state that among the coexistent pathology, the presence of chronic lymphocytic thyroiditis may be useful to help in explaining some clinical imaging and cytological findings. In this very large study that has been recently published, the authors try also to evaluate the outcome of these patients with associated thyroiditis. And they reported that in this model, without adjustment, the tumors without associated Hashimoto thyroiditis had a better recurrence-free survival results, but there was no association after adjusting for sex and age. I want to underline here that a fully adjusted model was not present, was not reported in this study, and that here the recurrence-free survival indicated only the structural recurrence. And in the meta-analysis that we have already seen, the authors also try to address the outcome of the 2 groups, including the 16 studies that reported information about the outcome. And as you can see, with these 16 studies, with around 15,000 patients, the authors reported that Hashimoto thyroiditis associated to papillary thyroid cancer can improve the outcome since they had a lower risk of recurrence compared to the other group. So the question is the question answered? We already have an answer. I want to underline some points. First of all, that the large majority of the studies in this meta-analysis are retrospective. Moreover, the inclusion criteria that the several studies used were different. And also the definition of recurrence and the management of patients in the different studies was not homogeneous. And here I want to show you this information about these 16 studies. At the end, we have the last study that was published just slightly later, so it was not included in the meta-analysis. But as you can see, the large majority of the studies were retrospective. The cohorts were variables among the studies, and also information about treatment in many cases were lacking. And also, as regards the use of radioactive iodine treatment, as you can see, this information was reported only in few cases. And also the use of radioiodine was not consistent among studies, with some with a large use in some cases in all patients in some studies. For this reason, we decided to perform this study in order to obtain more reliable information. And we, on this topic, on the association between differentiated thyroid carcinoma and autoimmune thyroiditis. And we used the clinical features and outcome of patients followed by centers participating into the Italian Thyroid Cancer Observatory, the ITCO. What is the ITCO? ITCO is a web-based database of thyroid cancer, including all histotypes. So not only differentiated thyroid carcinoma, but also medullary thyroid carcinoma and anaplastic. All information are prospectively collected, and ITCO coordinates observational studies where all patients with a new diagnosis of thyroid tumors are included, so are enrolled in this study. This study is also recorded on clinicaltrials.gov. At baseline, all the information about the clinical characteristics of the patients, the pathological features, the treatment that they received are recorded. And we have a primary outcome, which is the disease persistence or recurrence, and secondary outcomes that include the response to primary therapy and secondary treatments at different time points. We have the evaluation at 1 year, 3 years, 5 years, and 10 years. For this study, we enrolled patients since 2013, when the ITCO started, and the data lock was scheduled in November 2021. At that point, we had more than 10,000 patients in the database. We applied the following inclusion criteria. In particular, patients had a confirmed histological diagnosis of differentiated thyroid carcinoma. So we excluded all diagnoses of medullary thyroid carcinoma, NIPTP, and well-differentiated tumor with uncertain malignant potential. We define thyroiditis on the presence of both thyroperoxidase and thyroglobulin antibody levels, and at least one of the following between anamnestic data consistent with the autoimmune thyroiditis. Information about the ultrasound was used, so there were characteristic ultrasound features before surgery that were diagnostic for thyroiditis, of course, and or the histological description of a diffuse inflammatory infiltrate in the pathological report. And then we included only the patient for whom we had all the information on the initial treatment and information about tumor characteristics for the ATA risk assessment at baseline, and of course at the 1-year follow-up visit in order to classify the estimated treatment response. So from the original cohort of more than 10,000 patients, at the end, at the 1-year follow-up visit, we had 4,233 patients. We evaluated the treatment response of these patients using the guidelines of the American Thyroid Association. Therefore, we define excellent response patients that had a thyroglobulin less than 0.2 or stimulated thyroglobulin less than 1 with negative thyroglobulin antibodies. The indeterminate response included patients with thyroglobulin between 0.2 and 1 or stimulated thyroglobulin between 1 and 10, and or patients with positive thyroglobulin antibody, in every case with negative imaging. The biochemical incomplete response included patients with thyroglobulin higher than 1 or stimulated thyroglobulin higher than 10 with negative imaging, and the structural incomplete response when the imaging was positive. So since we had only one time point, we were not able to evaluate the trend of thyroglobulin antibodies. So we were not able to discriminate between patients with increasing levels of thyroglobulin antibodies or stable or decreasing. And we decided to include all these patients in the indeterminate response. So the biochemical incomplete response in this study included only patients with measurable thyroglobulin levels. And now I will present the result of the study. So this is the description of the cohort, but I want to underline the information about the associated thyroiditis. We had 1,552 patients with a differentiated thyroid carcinoma associated to thyroiditis. That means 1/3 of the whole cohort. And if we look at the different to the several characteristics, the association with the associated thyroiditis was reported in particular in patients with a female gender that was more frequent, and this is was expected since thyroiditis is more frequent in women. The age was significantly lower, so these patients were younger when associated thyroiditis was reported, and the tumor size was smaller. So we tried also to explain the results that patients were younger and with a smaller tumor, since probably these patients also perform more often thyroid ultrasound or exams that were able to diagnose earlier the thyroid tumor. This tumor with associated thyroiditis were treated less aggressively in our cohort, so the radioactive iodine was used less frequently, and also the next dissection was performed less frequently. And as already also reported in the previous meta-analysis, the associated thyroiditis was reported more frequently in papillary thyroid carcinoma. We also reported a difference regarding the focality of these tumors, and also this result was in line with the results of the previous meta-analysis. In particular, patients with associated thyroiditis more frequently had multifocal tumor, in particular a bilateral tumor. And we did not report any association with the extrathyroidal extension, lymph node metastasis, vascular invasion, and distant metastasis. But patients with associated thyroiditis more frequently at the low and in the intermediate ATA risk tumors, while the high risk tumors was reported more frequently in tumors without associated thyroiditis. So in conclusion, we can say that these tumors with associated thyroiditis seems to have a less aggressive presentation. We then evaluated the response to treatment after 1 year from the initial treatment, and we had that around 80% of patients had an excellent response. Only 3.3% of patients had a structural incomplete response after 1 year, and among them, as you can see, almost 3/4 of these patients had a locoregional disease. We then evaluated the difference between the two groups, the patients with associated thyroiditis and the patients without associated thyroiditis. we decided to perform this evaluation at 1 year, since we wanted to reveal the real impact of thyroiditis on cancer behavior. So without the additional treatments that would have mitigated the possible effect of thyroiditis. And we reported, after just 1 year, that the structural incomplete response were similar between the two groups. But we had, in patients with thyroiditis, a more frequently finding of a biochemical incomplete response and an indeterminate response. We then decided to perform a propensity score matching. So we decided to match 1-to-1 all our cases in accordance to several clinical characteristics such as age and sex, histological characteristics such as multifocality, tumor size, extrathyroidal extension, and so on, and also in accordance with the treatment. So also not only the use of radioactive iodine, but also the activity of radioiodine that was administered. So in the end, we had two groups that were completely similar, each of 1,552 patients, that differed only regarding the associated thyroiditis. And after matching, we then evaluated the evidence of disease that was defined in the first analysis as a structural incomplete and biochemical incomplete response, and in the second analysis as only structural incomplete response. And if the evidence of disease is defined as a structural incomplete and biochemical incomplete response, the evidence of disease is more frequent, significantly more frequent in patients with associated thyroiditis. And as you can see, the odds ratio in this case is almost of 2, which means that these patients have a 2 times higher risk of having an evidence of disease defined as a structural and biochemical. But when we evaluate the evidence of disease as only structural incomplete response compared to the excellent indeterminate biochemical, as you can see, we did not report any difference between the two groups, and the odds ratio is close to 1. So the difference is mainly because of biochemical incomplete response that was reported to be more frequent in patients with associated thyroiditis. And if we look at the only biochemical incomplete response, as you can see, we had 4% of patients with associated thyroiditis having a biochemical incomplete response compared to the 1.5% in the other group. The evidence of biochemical incomplete response in case of thyroiditis had an odds ratio of 2.6. Of course, our study had some limitation. First of all, the definition of the associated thyroiditis was based on several criteria: the biochemical data, the ultrasonographic, and also the histological findings. One of the limitations is the lack of the revision of all the samples. I have to anticipate that we have already planned to perform another study with including all patients for whom we could revise the specimens. So we could have a more homogeneous, more coherent definition of thyroiditis. The second limitation is the follow-up period of only 1 year. But our aim in this study was not to see the final outcome of these patients, but to demonstrate the impact of thyroiditis on cancer behavior. So what happens just after surgery and radioactive iodine when needed. So just after the initial treatment. And third, the third limitation is that the indeterminate responses were probably overestimated in our study, in particular regarding the patients with associated thyroiditis, since we were not able to evaluate the trend of thyroglobulin antibodies. However, since these patients were included in the indeterminate response, these results, the lack of including these patients in the biochemical incomplete response when thyroglobulin levels were increasing can only reinforce our results, because probably the number of patients with associated thyroiditis and the biochemical incomplete response would have been even higher. So, in conclusion, in this large prospective series with differentiated thyroid carcinoma, less than 10% of patients had a structural or biochemical incomplete response at 1 year follow-up after initial treatment. So, demonstrating for another time that these patients have a very good prognosis. Autoimmune thyroiditis does not have an impact on persistence in terms of structural disease, but biochemical persistence was more frequent in the group with associated thyroiditis compared to patients without associated thyroiditis. We then try to try to explain why these patients with associated thyroiditis had more frequently a biochemical incomplete response. And we just speculated that probably this higher risk is because patients with autoimmune thyroiditis may be likely have the persistence of the thyroid residue after the initial treatment. Indeed, in this scale, the thyroidectomy difficulty scale proposed by the surgeons report that it's more difficult in achieve a complete surgical thyroid removal in patients with coexisting autoimmune thyroiditis, since these glands may have a lower mobility and a higher fibrosis. Future research will show the outcome of patients with biochemical incomplete response with associated thyroiditis after a longer follow-up. We are planning to perform this analysis also at the 5-year time point. And this may inform clinicians about the need to perform additional treatments in these patients with biochemical incomplete response and associated thyroiditis, or we may demonstrate if further treatment may be avoided in this subgroup of patients with biochemical incomplete response with associated thyroiditis. And with this slide, I want to thank all people that make this study possible, my mentor, Professor Laura Fugazzola, and the group of Rome with the statistician, Dottoressa Silvia Delia, and Dr. Giorgio Grani, Professor Cosimo Durante, and Professor Sebastiano Filetti, and of course, all the centers that joined ITCO and provided their data. And of course, I want to thank you for your attention.
Okay, now my turn. And thank you for the invitation. And it's good to join today's discussion on the association between Hashimoto thyroiditis as well as, papillary thyroid cancer. And both thyroid diseases are very hot topics and very, common disease in the population. So I have nothing to disclose. Just now, we just heard Dr. De Leo introduce their excellent work. So in the next 15 minutes, I would like to share with you some other evidence regarding this topic. The first work was done by Johns Hopkins, and this study was performed to celebrate the centennial of Hashimoto thyroiditis. So the authors in this study, they reveal the surgical pathology archives of the Johns Hopkins Hospital for cases of Hashimoto thyroiditis, spanning the period from May 1889 to October 2012. Approximately 15,000 thyroidectomies were performed at this hospital over these 124 years. And then the authors found 867 cases of Hashimoto thyroiditis between 1942 to 2012, representing 6% of all thyroidectomies. So Hashimoto thyroiditis was a sole pathological finding in 462 cases. So shown in these slides, this study found that the increased incidence of papillary thyroid cancer observed was paralleled with the increase in both the forms of PTC associated with Hashimoto thyroiditis. And also they found that PTC, if the PTC is the initial lesion, which then induce the lymphocytic infiltration that in some patients progresses to assume the features of full-blown Hashimoto thyroiditis. So that's a very interesting topic. And after then, there is another study. Actually, this study, I was one of the co-authors. So this study was done in Brigham Women's Hospital, and this is a cohort analysis of more than 9,000 consecutive patients with more than 20,000 nodules bigger than 1 centimeter. And in this study, we used the definition of Hashimoto thyroiditis, included the first elevated TPO antibody and all diffused heterogeneity on ultrasound, and all diffused lymphocytic thyroiditis on histopathology. So a total of 2,651 patients, almost 27% were diagnosed with Hashimoto thyroiditis, and 3,895 Hashimoto nodules, and almost 10,000 non-Hashimoto nodules were biopsied. So in this study, one finding is the proportion of nodules with indeterminate and malignant cytology was higher in the Hashimoto thyroiditis group than in the non-Hashimoto thyroiditis group. And another finding is cell cancer in Bethesda 2. Actually, this cytology should be benign cytology, but cell cancer in Bethesda 2 cytology is more common in Hashimoto group than non-Hashimoto patients, which means that having Hashimoto thyroiditis is related to a higher rate of false negative and false positive FNA results. So Hashimoto thyroiditis is also related to a higher rate of thyroid cancer. So that's our main findings of our study. And in this study, cell cancers with and without coexisting Hashimoto thyroiditis actually are comparable in cancer pathological characteristics. And the third study is a nested case control study, and also this study was done in the United States. And in this study, 451 incident cases of papillary cell cancer were compared with same number of matched control. Long-standing prior cell autoimmunity, which means TPO antibody and TG antibody positive 7 to 10 years ahead of time and 3 to 5 years ahead of time in both groups were compared. So in this study, the results show that prior cell autoimmunity was associated with thyroid cancer. It is also indicated that increasing risk of thyroid cancer was related to the higher TPO antibody titers, but correlation, found in this study does not represent causality. Screening for cell cancer in those with cell autoimmunity because of the risk of actually screening for cell cancer in those with thyroid TPO antibody or TG antibody are not recommended because of the risk of overdiagnosis. So the next study I'm going to present is from Korea, and this study used the National Health Insurance Service National Sample Cohort. Incidence of thyroid cancer was analyzed in people with 8 kinds of autoimmune diseases, including Hashimoto thyroiditis and Graves' disease. And they compared the incidence of thyroid cancer versus people without any autoimmune diseases. Among 2,825 patients with Hashimoto thyroiditis, the incidence of cell cancer was 2.55 while the incidence of control group was only 0.85%. So it's significantly different. So according to the hazard ratio, Hashimoto thyroiditis and Graves' disease are associated with a higher risk of thyroid cancer. But again, the hazard ratio are not a relative risk of event happening in one group compared to another, rather than absolute risk. So the last study I'm going to present actually was shown by Dr. De Leo, and this study is from China. The study was done in one of the biggest cancer centers in China. So this is a retrospective analysis of 9,210 patients with papillary cell cancer. The definition of Hashimoto thyroiditis was based on post-operative histopathology. A total of 1,751 patients were diagnosed with Hashimoto thyroiditis. So the incidence in this group was around 20%. So the results shown PTC coexisting with Hashimoto thyroiditis was smaller, less extrathyroidal extension, less lateral lymph nodes metastasis, and more stage 1 patients. So tables shown here indicate aggressive characteristics at presentation of papillary cell cancer and OR ratios for coexistence versus absence of Hashimoto thyroiditis. So apparently, patients with existing Hashimoto thyroiditis had less aggressive characteristics than patients without Hashimoto thyroiditis. And there were 279 deaths, disease-specific deaths in Hashimoto thyroiditis group and non-Hashimoto thyroiditis group, respectively. So you can see the disease-specific deaths of PTC with Hashimoto thyroiditis is indeed reduced. And similarly, there were 133 structural recurrence in Hashimoto thyroiditis group and non-Hashimoto thyroiditis group, respectively. So this study only focused on structural recurrence, not biochemical recurrence. So I guess probably because in Hashimoto thyroiditis, the TG antibody, most of these patients will have positive TG antibody. So which means TG is not reliable to predict a recurrence. So anyway, the recurrence risk of papillary cell cancer with Hashimoto thyroiditis is reduced, although there is only a tendency after adjusting for sex and age. So it is noted that the diagnostic criteria for Hashimoto thyroiditis, in fact, they influences the association between Hashimoto thyroiditis and survival. So isolated TPO antibody positive, but without any pathological evidence of Hashimoto thyroiditis, was not associated with a better survival. This reminds us that when we discuss the association between Hashimoto thyroiditis and the prognosis of papillary cell cancer, the definition of Hashimoto thyroiditis should be clarified. So taken together in this cohort study, patients with coexisting Hashimoto thyroiditis had less aggressive characteristics at presentation and better outcomes of papillary cell cancer than those patients without Hashimoto thyroiditis. So the findings suggest that autoimmune thyroiditis may have a protective role in association with cell cancer. So as we all know, the above-mentioned studies, actually, they are all observational studies, only provides evidence of association, but not causality. So if we want to know causality, either randomized trials or Mendelian randomization analysis as needed. So recently, our team tried to study causality using Mandarin randomization analysis. So these are some genetics database we used. The results shown that genetically autoimmune thyroiditis does not increase the risk of thyroid cancer, which does not support Hashimoto as the cause of papillary thyroid cancer. So to summarize my presentation today, Hashimoto thyroiditis is associated with thyroid cancer, but there is still controversy over whether it is a carcinogenic factor, and the coexistence of Hashimoto thyroiditis may restrict the progression of thyroid cancer and associate with better prognosis. And the reason for improved prognosis may be related to the increase in lymphocyte infiltration. So that's all my presentation today. So many thanks for your attention. Again, congratulations to Dr. De Leo for their excellent work today. Thank you so much.
Thank you both. That is really a terrific discussion and wonderful presentation. Again, I want to ask our listeners if they have questions, please send those in. So, have we resolved this issue now? Do we need any additional studies other than to try to understand this potential for some degree of protection from the lymphocytic infiltrate? Is this have we exhausted this topic, or is there yet an unanswered question?
May I answer?
Sure.
I think that after our study, probably we have even more questions because, because what we had in the previous studies was that as regards the outcome, the characteristics of these tumors with associated thyroiditis, is that the outcome was good, but the outcome was defined only as a structural persistence. With this study, we confirmed that the structural persistence is similar, is the same, but we probably added something more, that probably the biochemical persistence is different. We performed this analysis at 1 year for that reason, because we want to understand if there was a difference just after the initial treatment. So we need to perform a first study to underscore if with a longer follow-up there's something different. Because my feeling is that in the biochemical incomplete responses, we have several types, let's say, of at least two kinds of responses, because there are some persistence that probably are, let's say, very small lymph nodes that we are not able to detect, or something different that we are still not able to detect. And there are other situations that are more like, let's say, probably benign conditions, okay? And probably in these patients with associated thyroiditis, probably we are in the group of patients with, like, let's say, with a more benign situation. So probably with the longer follow-up, we need to understand what happens. And also we need to understand if we need to do something to improve the outcome at the final follow-up with after a longer follow-up, because probably since they are probably not a real persistence, probably we do not need to let's say use several administration of the radioactive iodine, because probably they will be cured in the long term.
Okay, Dr. Guan.
Yes, I think there's still many questions about this topic. Although I already present several evidence as well as Dr. De Leo's evidence, but still, I think one key question is how do we diagnose Hashimoto thyroiditis? Because, you know, in Brigham Women's Hospital study as well as Dr. De Leo's study, we use TPO antibody, TG antibody, and ultrasound as well as pathology, you know, as the definition of Hashimoto thyroiditis. But you know, sometimes positive TPO antibody and TG antibody doesn't mean this patient must have Hashimoto thyroiditis. So I guess, as we can see in our clinic, lots of patients or lots of people actually they are having a positive TPO antibody or TG antibody. It doesn't mean they all have Hashimoto thyroiditis. I guess, you know, we see some studies has controversials on the relationship between Hashimoto thyroiditis and prognosis and incidence of papillary thyroid cancer just because they use different criteria to diagnose Hashimoto thyroiditis. So we still need some more studies using uniform or at least, for example, pathology or antibody or ultrasound. So we still need some more research. And another question we need to answer is which caused the relationship between, I mean, the real reason behind the correlation of Hashimoto thyroiditis and the papillary thyroid cancer. We try to find if Hashimoto thyroiditis is the reason and the papillary thyroid cancer is the result, but we failed to find this way. And probably, you know, when the first lesion of papillary thyroid cancer occurred, it caused lymphocytes infiltration and then Hashimoto thyroiditis. Probably the way is like this. So we still need some other question, other research to reveal which one comes first, which one is egg, which one is chicken. So that's my thoughts.
Great, terrific. We have a number of questions coming in, but let me just ask you very quickly before I get to those. Does your workup of a thyroid nodule in the presence of Hashimoto's differ than your workup of a non-Hashimoto's gland, the presence of a nodule?
Yeah.
Either Haixia or Simone, yes.
Okay, if I
sorry.
can, yeah,
Okay.
go ahead. Yeah, no problem.
Go ahead. You go ahead.
Okay, no, okay, yeah, go ahead. Because it's very simple answer. For me, it's the same. For me, it's the same. There is no difference. Just one thing is that we need to be careful in deciding which nodules we want to, in which nodule we want to perform a fine needle aspiration, because sometimes we can have some results that not reliable because of the thyroiditis. So we just need to be very careful in selecting the right nodules, but in general, the management is similar.
And so management, you don't change your approach. Obviously, it seemed like there was a higher incidence, Simone, of total thyroidectomy, and I'm wondering if that was related to the thyroid cancer or just the fact that we know these patients are going to be dependent, more higher likely dependence on thyroid hormone replacement. That was the reason. Do you just want to comment? If you could just comment on that, and then I'm going to get to our questions here.
Yeah, in general, it depends, because if we have the other thyroid lobe that is without nodules, in general, for me, it's okay to perform a lobectomy if, of course, the presumably tumors is a low risk tumor. So it's not a reason, even though we demonstrated with the study and also in the previous studies that the risk of multifocality is higher, is significantly higher. But to be honest, because also of the outcome of these tumors, I don't see that the total thyroidectomy is always needed in these patients. So, and as regards the replacement therapy, I think that if I suggest a lobectomy, is not because I want to avoid the replacement therapy, but because I want to decrease the risk of surgical side effects. So for me, the replacement therapy is something that I do not consider in the choice of a lobectomy or total thyroidectomy.
Okay. Haixia, do you have a comment?
Yeah, I totally agree with Dr. De Leo, but I want to add two comments. The first one is if this patient has Hashimoto thyroiditis and when we biopsy this nodule, keep in mind probably, the Bethesda 3 and Bethesda 4, those indeterminate cytology will be more often seen, just shown in our study from Brigham Women's Hospital's cohort. So that's one comment. And another comment is sometimes I do consider total thyroidectomy to, malignancies in Hashimoto thyroiditis patients because sometimes after the surgery, if this patient has a high risk, I would prefer total thyroidectomy because I want to easily follow up this kind of patients. So TG antibody usually won't damage, after lobectomy as shown in your study. So if these patients get total thyroidectomy, probably they do not have TG, and then TGAB can come down. So that's my opinion. So in these patients with the decreasing of TG antibody after total thyroidectomy, I will say, okay, this cancer was well treated, or at least, I do not worry too much about the recurrence or the persistence of this disease. Okay, that's my two comments.
Great. So let me get to our audience here. So Dr. Shah has one comment and a question. He comments that that Hashimoto's is so common in the U.S. that it is almost seen in 50% of our patients, and therefore, whether this is more of a statistical question rather than a true relation here or association. But he raises the question regarding surgical management, and I know both of our panelists are not surgeons, but commenting on the higher risk of surgery in the cohort of patients with Hashimoto's thyroiditis. Simone, do you want to comment on that?
Yeah, I will leave Dr. Guan to answer the question from Dr. Shah.
And first, about the prevalence of Hashimoto thyroiditis in a population, again, it's according to different diagnostic criteria. If we just use ultrasound, sometimes we can find half of our population will have Hashimoto thyroiditis. But again, ultrasound doesn't mean all this, heterogeneity means Hashimoto thyroiditis. So in our research, we do need to define a definition or define a criteria, but in our real, clinical practice, sometimes we do need to think about the criteria of Hashimoto thyroiditis. So that's my comments for this question.
Okay, and what about increased risk surgically here?
Yeah, if you want, I can. Of course, I'm not a surgeon, but I made this question to our surgeon that admitted that surgery is more complicated. So I reported the information with the thyroidectomy difficulty scale that was made by surgeons, and they state that performing a surgery when we have a thyroiditis can be more challenging. In particular, if we have an hyperthyroidism, this is not only because of fibrosis, but also because there is also a higher vascularity. So this can make the surgery more difficult. So this was the answer from a surgeon.
Great. Okay. Terrific. I'm sorry.
Another autoimmune thyroid disease, Graves' disease. Actually, I think Graves' disease and the thyroid cancer with Graves' disease. Actually, surgeons hate this kind of surgery allowed because Graves' disease is another condition in which operation is really difficult. Have more a higher risk to have some complications. Yeah. So.
Right. Okay. I would, as a surgeon, I would agree with your assessment here, as I'm sure, I suspect Dr. Shaha would concur based on his question. The question from Dr. Sanderson is related to the histology of coexisting papillary thyroid cancer and Hashimoto's, and whether or not the histological features are different for PTC in the presence of thyroiditis?
I don't think so. Yeah, I think the pathology, you mean the pathology of PTC?
Correct. That's
yeah.
Yes.
In Hashimoto thyroiditis, whether it's the same as in non-Hashimoto thyroiditis.
Correct.
I think the same, although I'm not a pathological expert, but I think the criteria should be the same. What do you think about that, Dr. De Leo?
Yeah, I agree with you. I think that are the same.
Okay.
I don't know if there is some reason, but I don't think so.
So Dr. Chen in the United States has raised the question of whether or not thyroglobulin, that's an elevation in thyroglobulin after treatment, is coming from the cancer or from the thyroid tissue. And do you want to comment on that?
Yeah, if I can say something here, this is a very good question because this is the point. Unfortunately, we are not able to discriminate thyroglobulin that is produced by the thyroid tissue or by metastasis, for example. So that was the reason because I said that we just speculated that the biochemical incomplete response in our patients was because of the thyroid tissue. But of course, we need the confirmation, and probably it's very hard to answer to this question because at the moment we are not able to assess this.
Great. One last question here relates to whether or not in your study there was any analysis of BRAF mutation in to help to enlighten whether or not that mutation was more common.
Yeah, in our study, we do not have this information, even though we are now collecting also genetic information, but I know the data are only few. I just can say that in some studies have addressed this issue and probably the association is less frequent with the BRAF. So, but in our study, this is something that we did not have this kind of information, yeah. But there should be a less frequent association with BRAF when there is an associated thyroiditis. Great.
So one last comment or question relates to the presence of inflammatory lymph nodes associated with thyroiditis and in general and in the presence of PTC. And that from a surgeon's perspective becomes very challenging because we don't know, it's very difficult to tell the difference, and you're left with the determination that you obviously would prefer not to have to go back and revisit in the event that one of those many lymph nodes that are commonly present harbors malignancy. Do you have any comments about the role of either central compartment lymph node dissection in patients with coexisting thyroiditis and PTC, or just any comments related to that topic? Simone?
Yeah, in general, as also we saw with the meta-analysis, the rate of lymph node metastasis is lower of the central neck sometimes it can be, it depends on the, like, for example, in ITCO, we had information from several centers. So the approach may be slightly different, but in general, seems that there is not a need to perform more frequently a neck dissection.
Great. Haixia, do you have any comment on that?
Yes, according to the Chinese cohort study, actually, the patients with Hashimoto thyroiditis, they showed less common lateral neck metastasis. So I think, sometimes we all know Hashimoto thyroiditis, they can see suspicious nodes in ultrasound, but after pathology examinations, it turns out not, a metastasis. So we need to be very careful to diagnose, lymph nodes metastasis in Hashimoto thyroiditis patients. So probably the FNA on lymph nodes metastasis prior to operation should be a good way to differentiate diagnosis. Yeah.
Great. I want to thank you both. I have a feeling we could talk for another hour on this topic. Thank you both for your presentation. Thank you for that wonderful paper, Dr. De Leo. And thank you to all our listeners for joining us this morning. We will be back again next week. Everybody have a great day.